Hello, I'm Paul Walker, medical oncologist of Circular Gene. I would like to welcome you to and present another case in our ongoing Circular Gene Molecular Tumor Board series. This is a 61-year-old female with a non-visceral soft tissue metastatic cutaneous melanoma, LDH normal. A liquid biopsy with plasma next-generation sequencing revealed the cell-free RNA plasma PDL1 highly expressed, greater than 50%. There was also a CDKN2A mutation. This can be a frequent somatic mutation in melanoma. However, looking at the mutant allele fraction of the CDKN2A at 49%, that immediately sparks a concern that this could well be a germline mutation, warranting germline testing, which would have significant impact for her as well as her family. Anytime there's a mutant allele fraction of greater than 40%, that crosses the threshold, sparking a concern that this could be a germline mutation warranting germline testing. The evolution of treating metastatic melanoma has had tremendous advances with immune checkpoint inhibitor therapy, and particularly in dual anti-PD-1 and anti-CTLA4 therapy. This was recently published in the Journal of Clinical Oncology, long-term outcomes with a combination of Nevo-IPI, 57% 5-year overall survival. This compared to 50% with Nevo, which is great, but 50% is better for those 7, whereas there's only 30% with IPI alone. There's also some interesting subsets in this study impacting the treatment decisions in melanoma. Looking at the BRAF wild-type subset of patients, there was no discernible difference between the combination of Nevo-IPI versus Nevo alone, clearly better than IPI alone. However, in the BRAF mutated subset of patients, a combination of anti-PD-1 and anti-CTLA4 was distinctly better than either single immune checkpoint inhibitor therapy. The whole evolution of treating BRAF mutated melanoma has also undergone changes because of the combination of Nevo-IPI, but also the gene DREAM sequence trial presented at the ASCO plenary series in last year. This was looking at BRAF mutated melanoma and a sequence of either upfront Nevo-IPI, dual immune checkpoint inhibitor therapy, then followed by a salvage TKI, or the converse, initial BRAF TKI, then followed by the salvage immune therapy. And there was a distinct overall survival improvement with the combination of upfront Nevo-IPI with 72% overall 2-year survival compared to 52% with upfront BRAF TKI. So clearly, upfront immune therapy, even in BRAF mutated melanoma, is a superior treatment approach. There's also been another advance in treating metastatic melanoma with the AntiLAG3 monoclonal antibody. LAG3 is a lymphocyte activation gene 3. It is expressed on CD4 and CD8 T cells. It's also expressed on Tregs, producing interleukin-10, TGF-beta and suppressing TILs, and in essence results in tumor-induced exhausted T cells. But there's also synergism with anti-LAG3 and anti-PD-1, PD-L1 therapy. This was a phase 3 study published in the New England Journal of Medicine earlier this year with the combination of anti-LAG3 monoclonal antibody and anti-PD-1 nivolumab versus Nevo alone. It certainly was not the anti-LAG3 Nevo combination versus Nevo-IPI. The relatlimab is a generic, Opdualag is the trade name of the anti-LAG3 monoclonal antibody, and there was a distinct progression-free survival benefit. However, that was only demonstrated when there was LAG3 IHC protein expression. When there was lack of LAG3 IHC protein expression, there was no significant benefit. There was also another subset of interest when there was PDL1 expression. There was a lack of the anti-LAG3 benefit. It was only in the patients that did not express PD-L1. In the BRAF subset of patients, there was no difference whether BRAF mutation or wild type. The importance of the CDKN2A germline mutation is very impactful. This can have a mutation prevalence of 20 to 40% of family syndromes of metastatic melanoma. There can also be other associated cancers, most frequently pancreatic adenocarcinomas associated with CDKN2A. There can also be other GI cancers, lung, adenomas, head and neck, as well as neural system tumors. Our melanoma Molecular Tumor Board recommendation was number 1, a combination of dual immune checkpoint inhibitor therapy with nivolumab and ipilimumab. Given the PD-L1 expression, even in the setting of soft tissue metastases in a normal LDH, it was felt that a LAG3 Nevo approach was not going to be as effective as the dual Nevo-IPI approach. Second, there's a recommendation to confirm the CDKN2A mutation within a discussion regarding any other personal cancer screenings and family cancer screening, including the need for active dermatologic care of her as well as any affected family members. I hope this was very helpful to put into perspective the utility of a liquid biopsy, plasma next generation sequencing, even in the setting of metastatic melanoma. Thank you.